Delighted to have with us Professor Gareth Morgan from the Department of Haematology at the Royal Marsden Hospital in London, England. Professor, thanks for stopping by.
Thank you very much.
You're working with treatment for patients with bisphosphonates. What can you tell us about the design of your study presented here at ASCO?
The study we're presenting here was a very large study in myeloma, probably the largest study ever done, that randomized nearly 2,000 patients. And the bottom line was they were randomized between Zometa, a new generation bisphosphonate, and Clodronate, an oral first generation bisphosphonate. And one of the important questions in this area has been who benefits most from these agents, and so we were really able to address this. And so we showed important data that for the first time we saw a clinical survival benefit for patients treated with Zometa, and this effect was independent of skeletal related events. We also were able to address the fact that something like 30% of patients present without bone disease with myeloma, and most of the guidelines have suggested that these patients don't get a bisphosphonate. However, in this study with the group that don't have bone disease, we showed that they benefited very significantly from the use of Zometa compared to Clodronate, showing for the first time that you shouldn't just restrict the use of these agents to patients with bone disease at presentation, but you should give them to all patients regardless of whether they have bone disease present or not. We asked a number of other questions as well in the context of this study, and I mentioned that there's a survival benefit. So we looked at the impact of Zometa compared to Clodronate for patients with and without bone disease on survival, and there was no impact on survival in the group that lacked bone disease, but there was a highly significant impact on survival in the group with bone disease. And the survival curves continued to separate with time, suggesting that you should stay on the bisphosphonates long term. The other thing that we were able to do, which is a bit more complicated, I guess, is that you can separate myeloma into risk groups based on their cytogenetic makeup. So we had fish-based cytogenetics on over 1,000 patients, and we split them into a high-risk and a low-risk group. The high-risk group were characterized by the 414 translocation, MAF translocation, 17p minus, and 1q plus. Anyway, the bottom line of the data was in that high-risk group, although the bisphosphonates worked, they weren't as effective as in the low-risk group. The benefit of Zometa over Clodronate was huge in the low-risk group, suggesting that if you have stable myeloma that you have for many years, that these agents really work in this group of patients to reduce their skeletal related events and to improve their survival. So I think this is very important data. And what I think it means to clinicians is, one, you should start these agents pretty early on in the course of the disease for patients with myeloma. Zometa seems to be one of the favored, the most powerful agent. We have the biggest data set compared to any of the other bisphosphonates in this setting with this agent. Not only is it clinically beneficial in reducing skeletal related events, it improves survival, and we show it's safe. There was no real problem with osteonecrosis of the jaw or with renal issues. So I'm very pleased with the results of this study, and I think it's up to the physicians out there now to start using this agent to improve the outcome for their patients.
This was not only a big study in terms of size, but you backed it up with some pretty big findings. What type of feedback have you gotten from the oncology community?
I think people are very excited about the data. I presented some of it last year in the New York meeting, and it was so well liked that we actually won a prize for the best abstract in the meeting. So I think the medical community appreciate the data, but not only that, I think it's good news for patients. These agents are pretty non-toxic, and it's actually improving their outcomes. And really, we're all about improving outcomes for patients, and I think this is why we really should start to use more of this agent in the clinic to improve these outcomes.
So now you feel it's not time to do more research, but rather get more people to take action on the research findings you've presented.
Yeah, I think so. I think we've answered the question. It's a very, very good agent. And I think it's now the gold standard that any new agent you introduce into the clinic for this purpose has to be compared against. And if you don't have that data and you don't show that you're doing better than this, then I think you shouldn't be using those agents. So I think it's beholden upon my colleagues out there to try and use this for their patients.
So where does Gareth Morgan go from here with this research project?
So we've got another trial running addressing another important or other important questions. Hopefully it's going to be as big, another 2,000 patient trial. And in the context of bone disease, what I think we need to look at next is not just inhibiting osteoclasts, which we've done up to now, but trying to see, can we stimulate bone formation so that we can improve the density of bone in these osteoporotic patients? And I think that's going to be possible.
Professor Morgan, thanks for stopping by and sharing information about your work.
Thanks very much. It was a pleasure to be with you.
Boy, you do big things over there in England. Weddings, clinical studies, everything's big.
Yeah, absolutely, but not as big as in America. Thank you very much.
Very, very, very nicely said. Professor Morgan joining us at ASCO 2011 in Chicago, Illinois, in the heart of America.